and welcome back to another video from HSTV. And in today's video I'm just going to do like a little study with me type video to get you guys motivated to study and to maybe motivate myself to stay in one position for hours on end. But anyway, as always, we've got plenty of work to be getting on with, I'm sure. If you're new to the channel, hello. I'm a first year medical student at the University of Edinburgh, and yeah, we're just gonna get on with a study with me video. I'm just gonna show you guys quickly what it is that I'm actually studying just now. Hopefully it'll take me around an hour to get through 3 lectures, and I'll be taking notes on my tab S7 Plus. So if you're interested about how I take notes, please do go check out my note-taking series, which I will link up there hopefully and down in the description as well. So yeah, I'll just show you guys quickly and then we'll get into it. So as you can see here, we're going to be looking at airways and airways disease. So I've got pulmonary airway disease 1, 2 and 3 to get through. So these are 3 lectures I'm going to be doing just now. I've got an 11-minute one, 11-minute one, and then I've got a 13-minute one. And as always, I'll be taking notes on my tab S7 Plus. And yeah, I'll just get through these 3. Probably take me around an hour. And yeah, we'll just get on with it. Oh, and just one more thing I guess I'll just add is I'm not going to put any music on this video, so you'll be hearing real-time voices, and it will be real-time video, no time-lapse. So it'll be a long video, but hopefully you guys enjoy. Okay, let's get on to it.
Disease, and in this segment we're going to consider the terms chronic bronchitis and emphysema, and also the clinical and pathological features of chronic obstructive pulmonary disease. Which forms a spectrum encompassing both chronic bronchitis and emphysema. Chronic bronchitis has a clinical definition which can be given, as you see here, as cough and sputum for 3 months in 2 consecutive years. The main etiologies or causes of chronic bronchitis are air pollution and cigarette smoking. air pollution was a more dominant factor in the etiology of chronic bronchitis in the past, particularly, for example, in the 1950s with the so-called smog, largely related to the use of coal fires. Now the disease is dominated by cigarette smoking. Clinically, the patients tend to be middle-aged heavy smokers, and they often present with recurrent low-grade bronchial infections, often termed exacerbations, and these infections are often related to relatively common organisms such as Haemophilus influenzae or Streptococcus pneumoniae, but they may also be initiated by viruses. In these patients, airways obstruction may be partially reversible, and so the principles applied to the pathophysiology and also the treatment of asthma apply in these patients, many of whom use the same inhalers as patients with asthma do. Chronic bronchitis tends to be a progressive disease, and with progression, what you often see is hypercapnia, which is carbon dioxide retention, coupled with hypoxia, which is reduction in blood oxygen levels, and these may, if chronic leads to pulmonary hypertension, which is particularly related to hypoxia, which causes pulmonary vasoconstriction. And eventually, with chronic pulmonary hypertension, the right ventricle of the heart will fail because it's pumping against the high pressure, leading to right ventricular failure. And in this context, this is often referred to as cor pulmonale, which means heart failure due to lung disease. The combination of hypoxia, which makes patients look cyanosed or blue, with right-sided heart failure, which gives them swollen ankles, leads to this rather unkind term blue bloater to describe these patients who are often overweight due to fluid retention and blue due to central cyanosis. The pathology of chronic bronchitis largely relates to the respiratory bronchioles, where there is a respiratory bronchiolitis affecting airways less than 2 millimeters in diameter. And this can lead to central lobular emphysema, which I'll come back to shortly. And you'll see straight away. away that there's a clear overlap between chronic bronchitis and emphysema. These patients also demonstrate mucus hypersecretion related to mucus gland hypertrophy, and this is part of their frequent cough, and also chronic bronchial inflammation, which if long-standing, can induce squamous metaplasia with an increased risk of malignancy. The normal bronchial epithelium is respiratory in type, made up of ciliated and mucus-secreting cells, but chronic damage related to, for example, cigarette smoking can cause that epithelium to change into a squamous epithelium, which is relatively unstable and can produce tumors. Emphysema, by contrast, has an anatomical definition, one of which is given here as irreversible dilatation of acinar spaces with destruction of walls. The traditional definition is confined to alveoli, so irreversible dilatation of alveolar spaces, but it is often extended to include the respiratory bronchioles, particularly to encompass the overlap with chronic bronchitis. And this anatomical change is associated with loss of surface area for gas exchange, and this is responsible for the downstream pathophysiology and the clinical features. The classification of emphysema is anatomical, and you'll see here at the top. The classification of emphysema is responsible. For the downstream pathophysiology and the clinical features. The classification of emphysema is anatomical, and you'll see here at the top the central lobular emphysema associated with chronic bronchitis. So the respiratory lobule is everything supplied by a respiratory bronchiole. So that's the respiratory bronchiole plus its associated acini, alveolar spaces. Sorry. The acinus is everything supplied by, or therefore distal to, a terminal bronchiole. So that incorporates the respiratory bronchioles and the alveolar spaces. Panlobular emphysema or panacinar emphysema therefore includes both respiratory bronchioles and alveolar spaces. Paraseptal emphysema is often found adjacent to pleural surfaces or to scar tissue and really relates to a localized dilatation of alveolar spaces. And then irregular emphysema is a combination of the different components. And paraseptal and irregular emphysema tend to be used pathologically rather than clinically. So central ocular emphysema is strongly associated with smoking. It can also be seen in some patients with pneumoconiosis, that's dust-related lung disease, particularly coal workers, so that's coal workers' pneumoconiosis. It's most common in the upper lobes, and respiratory Bronchiolitis is often present, and you'll remember that was one of the features of chronic bronchitis. Panlobular or panacinar emphysema usually affect left lung. Features of chronic bronchitis. Panlobular or panacinar emphysema usually affects the lower lobes, and the lungs here are over this. Extended. And one particular association of panlobular pan-asthma emphysema is alpha-1 antitrypsin deficiency, which is a genetic disorder associated with deficiency of this particular enzyme. And the development of emphysema in patients with this disorder is markedly accelerated in smokers. So the combination of alpha-1 antitrypsin deficiency and smoking is particularly likely to lead to pan-asthma or panlobular emphysema. And if you see young patients with emphysema, then consider this as an underlying genetic problem. These other forms of emphysema, paraseptal, irregular, are, as I said already, pathological. Terms and have weak clinical correlates. Other terms you may hear: bullous emphysema. This simply refers to the presence of distended areas greater than 10 millimeters or 1 centimeter in diameter. So again, an analogy. Definition, often used in association with abnormalities seen on radiology, where you can pick up these bullae, so-called. Interstitial emphysema isn't really emphysema as defined here. This refers to the presence of air in the interstitial tissues of the lung, so within the substance of the lung and sometimes extending into the mediastinum. And this is associated with a post-surgical phenomenon, or sometimes with chest trauma, where air is introduced traumatically into the soft tissues of the lungs. Now, the clinical features of, if you like, a pure emphysema are hyperventilation, normal partial pressure of oxygen in the blood, and a normal or even low partial pressure of carbon dioxide. So here the respiratory drive is maintained so that the individual hyperventilates, they breathe more quickly than normally in order to make maintain their oxygen level, and in so doing they often blow off more carbon dioxide until their CO2 level will be low. They tend not to develop cardiac failure early. So because their PO2 is normal, they are pink, they're not blue like the blue bloater, and because they are hyperventilating, they tend to be called pink puffers. The work of breathing in these patients is high, so it's associated often with weight loss, and these patients can really lose quite a lot of weight as a result purely of their emphysema. Eventually they will often develop right ventricular failure, largely due to loss of area for gas exchange. So that's rather than the pulmonary vasoconstriction associated with pulmonary hypertension in people with predominant chronic bronchitis. However, in most patients, there is often coexistence of chronic bronchitis and emphysema, in which case the clinical features are mixed. So these descriptions of blue bloaters and pink puffers represent the extremes of this spectrum of disease. So here's an example of emphysema involving the lung, and you will see that there's actually relatively little to see. In fact, the most dominant feature is the presence of this black pigment within the lung, which is actually fairly common at autopsy when you look at lungs from normal people or people who died from some other cause. And this is environmental carbon that has become deposited in the lung, often within macrophages within the lung substance. But it's often increased in people with emphysema because of their increased environmental exposure to these pollutants. And you'll see here there are some enlarged spaces that are more than a centimetre in diameter, so these are bullies. So this is bullous emphysema. So chronic obstructive pulmonary disease represents a combination of the features of chronic bronchitis and emphysema. Emphysema, and most patients exhibit a mixture of features. This disorder is typically assessed using pulmonary function tests. For example, an FEV1 to FVC ratio of less than 0.7 is often used for diagnosis of COPD, and the percent predicted FEV1 to assess its severity, remembering that FEV1 is forced expiratory volume in 1 second, and FVC is forced vital capacity. And these are relatively easy parameters to measure in patients using spirometry. So we've covered the terms chronic bronchitis and emphysema, demonstrating that chronic bronchitis This is the first in a set of 3, moving on to chronic bronchitis and emphysema, then think of in relation to respiratory infectives, namely factors relating to risk of respiratory infection, and then think about bronchitis, bronchiolitis, and airways obstruction. The host defenses that we have in relation to respiratory infections start from our upper airway. The host defenses, this first segment I'll concentrate on the first 3 objectives, namely factors relating to risk of respiratory infection, and these to some extent explain the marked variation in the effect of infectious agents in different people. So starting at the top, we have the cough reflex, we have the cilia lining our respiratory tract, at least the upper respiratory tract. We have the production of mucus, which can allow us to remove organisms from our respiratory tree. We have a local immune response, often producing immunoglobulin type A, and it's known that antibody deficiencies involving IgA are associated with increased respiratory infection risk. We have immunosuppression, where there is a generalized immunosuppression of the immune system through disease or drugs, and that increases risk of respiratory infection. Macrophage dysfunction, which can be genetic or acquired. And then finally, and quite commonly, pulmonary edema, so the accumulation of fluid in the lung, often related to heart failure, is a risk factor, particularly for lower respiratory tract infection. So here we have it in diagrammatic form. So starting at the top, we have a cough reflex if anything gets to the back of our throat, so we're coughing up. We have the cilial escalator, so-called, in the trachea and the main bronchi, so if organisms get further down, they can be wafted back up the airway to or in saliva. And further down we have defenses with small particles to be moved back upwards towards the mouth, and the production of may make us feel a little bit unwell. But there is no involvement. It can also involve the larynx and trachea, as I mentioned. And primary bronchiolitis is really a viral disease, often in children. Classic cause is respiratory syncytial virus, and because this involves smaller airways, it tends to be dominated by tachypnea, which is fast breathing, and dyspnea, which is uncomfortable or symptomatic breathing. So somebody with tachypnea, the parents will say that the child is breathing much more quickly than usual and seems to be in distress. There are some rarer types, follicular bronchiolitis, bronchiolitis obliterans. These are associated with specific lung diseases, and I'm not going to talk about them anymore here. Moving on to airways obstruction, you can divide airways obstruction into localized and generalized or diffuse, and they are quite distinct. Localized airway obstruction can be considered in the same way as obstruction of any hollow viscus or tube. Either there's a lesion outside the wall squashing the tube, for example, in this case a large lymph node, such as a mediastinal lymph node. There may be a lesion in the wall of the airway, for example a tumor. Or there may be a lesion in the lumen stuck down the centre of the pipe, if you like, such as a foreign body, classic being inhalation of peanuts by children, for example. And this causes distal collapse, so you obstruct the airway, air cannot get past that obstruction. Eventually that's all absorbed and the lung collapses. Or overinflation, if the obstruction produces a one-way valve, in other words, air can get past it during inspiration but can't get out again, then that segment of the lung will overinflate. And that distal segment may accumulate fat or get infected, or both. And so you end up with what's called a lipid pneumonia or an infected pneumonia, and the patient may present with a bacterial pneumonia, which is secondary to an obstruction. And it's always important to remember that, particularly in older patients, that they may present with a pneumonia, but that pneumonia is being caused by a lung cancer. Very often these patients will have normal pulmonary function tests if they have no underlying lung disease, because the rest of their lung is normal and compensates for the lack of function of a particular segment. So here we have an example of a localized obstruction. Here's the trachea, this is the main bronchus, and this is a subdivision of a main bronchus, and there's something obstructing the lumen in this case, not the wall or squashing from outside, but a luminal obstruction, and you get a downstream dilatation of the airways and the possibility of lipid or infected pneumonia, and bronchiectasis, which I'll come back to in another lecture segment, where the airway is irreversibly dilated. This tends to occur in more chronic obstruction rather than an acute obstruction. So diffuse obstructive airways disease, this is much more common. It can be reversible and intermittent, which is essentially asthma, or irreversible and persistent, which is associated with chronic obstructive pulmonary disease, but also with genetic disorders such as cystic fibrosis. This is centered on bronchi and bronchioles, so it affects smaller airways as well, and it's a diffuse disease because many airways are involved, and because it is diffusely distributed throughout the lung, then you do see abnormal lung function tests, and they show this so-called obstructive pattern, where there is a reduction in the vital capacity and also a reduced FEV1 to FVC ratio. This stands for forced expiratory volume in 1 second as a ratio of the forced vital capacity. So that's how much air you can push out in 1 second as a percentage of the total amount of air you can push out when you force it. And you also, of course, see reduced peak expiratory flow rate. And the peak flow, so-called, is used very commonly to monitor patients with asthma. So there are several clinical pathological entities that fall under this heading. The first is chronic bronchitis, second is emphysema, and I'll come back to both of those in more detail in the lecture segment where I deal with chronic obstructive pulmonary disease. Similarly with asthma, which is very common and is by definition reversible. There's a reversible element to this, and I'll talk about that specifically in another lecture segment, and similarly bronchiectasis, which I'll talk about at the end of the third lecture segment. It's important to recognize that chronic obstructive pulmonary disease is a spectrum, and it's a spectrum of coexistence of chronic bronchitis and emphysema, which I will come to the definitions of. They're rather different from one another. Chronic bronchitis is defined clinically, and emphysema is defined pathologically, so it's perhaps no surprise that they tend to overlap to some extent in individual patients. So we've looked at factors that contribute to increased risk of the respiratory infection. Those can be This is the third and final lecture segment on pulmonary airways disease. And in this segment, I'm going to talk about the pathological features of asthma and consider the causes, pathological and clinical features of bronchiectasis. So starting with a definition of asthma, this can be defined as reversible wheezy dyspnea, that is breathlessness that is reversible and associated with a wheeze. It is often related to increased irritability of the bronchial tree with paroxysmal, that's variable airway narrowing. There are 5 broad etiological categories, the most common of which is atopic asthma, which is related to allergy. non-atopic asthma, which is not related to allergy, aspirin-induced asthma, which is important because of the sensitivity of these patients to non-steroidal anti-inflammatory drugs, occupational asthma, which is often overlapping with atopic asthma, and finally, allergic bronchopulmonary aspergillosis, or ABPA, which is an allergic response to Aspergillus fungus. It's important to recognize that asthma is a serious disorder. It can be associated on occasion with sudden death, and this is related specifically to mucus plugging. You see here in this image the trachea and both left and right main bronchi in an individual who died of sudden acute asthma, where there's a marked outpouring of mucus which obstructs the airways, leads to respiratory failure and death. And you can see down the bottom histologically these bronchi, seen here in cross-section in the histological image, are completely obstructed by mucus. So although in most people asthma is a relatively mild disorder, treatable using simple inhaled medication, in some, and unpredictably, it can lead to sudden death. So it's important that patients with asthma adhere to their medication as prescribed by their practitioner. The commonest form of asthma is atopic asthma. This is associated with allergy and can be triggered by a variety of factors, such as dusts, pollen, house dust mite, etc. In individual patients, this may be associated with atopic eczema and also hay fever, and some people have all three. In these patients, bronchoconstriction is mediated by a type 1 hypersensitivity reaction. That's a reaction related to IgE antibodies, and I'll talk about that in a moment. So this hypersensitivity reaction leads to bronchial obstruction through a variety of mechanisms, the most dominant being bronchoconstriction with distal overinflation or collapse. Similarly to localized airways obstruction that I talked about previously, this bronchoconstriction can lead to a collapse of distal lung, or more commonly, overinflation of distal lungs, because these narrowed airways act like the one-way valve that I described previously. So air can be inhaled into the lung, but not exhaled from the lung, leading to overinflation. There is mucus plugging of bronchi, bronchial inflammation, mucus gland hypertrophy, which contributes to the mucus production. In chronic cases, bronchial wall smooth muscle hypertrophy can produce an irreversible element to the airways obstruction, as can thickening of bronchial basement membranes. This is much less common in patients whose asthma is well controlled. So here we have a cartoon showing the factors contributing to airways obstruction in atopic asthma. So these individuals have circulating specific IgE antibodies to inhaled allergens. So when a relevant allergen is inhaled, it comes across the circulating IgE. This antigen-antibody complex, the allergen here is the antigen, and the antibody here is IgE. These bind to the surface of mast cells, which degranulate and release a number of inflammatory mediators, including histamine and others. And these mediators induce bronchoconstriction, mucus hypersecretion, inflammation, and edema in the bronchi with consequent obstruction. So you can see with these different mechanisms of bronchial obstruction how different pharmacological approaches can be taken to the reversal of these components. For example, beta-2 agonists such as salbutamol or Ventolin can be used to reverse the bronchoconstriction, the smooth muscle contraction, and inhaled steroids, which are anti-inflammatory, can reduce the inflammation and the edema. Non-atopic asthma is not allergy-related. It is, however, associated with recurrent infections, and in these patients, skin testing is negative. This is an important investigation. Very often in patients with atopic asthma, skin prick testing can identify the triggering allergens, which can then be avoided by the individuals, and this can help the management of asthma quite considerably. However, in this non-atopic form, the skin tests are negative. Aspirin-induced asthma is associated with recurrent rhinitis, which is nasal inflammation, nasal polyps, and urticaria, which is a bumpy, itchy skin rash. The mechanisms here are unclear, but it's important to recognize because these patients are sensitive to non-steroidal anti-inflammatory drugs, such as aspirin and ibuprofen and others, which can bring on asthma attacks. The mechanism is probably related to some aspect of inflammation, perhaps involving prostaglandins and leukotrienes, which is logical in the sense that the non-steroidal anti-inflammatory drugs act through this mechanism. Occupational asthma is, as you might expect, hypersensitivity to an inhaled allergen that is related to an individual's occupation. One example would be a pine wood allergy. If somebody is sawing pine, releasing pine antigens, then that may induce an asthma attack. It's important to recognise this may also be non-specific in those with hyperreactive airways. So a normal airway can react if exposed to sufficiently noxious stimulus, and that's a non-allergic reaction. But is associated with bronchiectasis partly because of the mucus plugging, which may be chronic. It's important that you don't confuse this with the term aspergilloma, which literally means tumour of fungus, or tumour of aspergillus, which is a fungal ball, and that is produced by colonisation of a pre-existing cavity in the lung, much more common in the past related to tuberculosis. Bronchiectasis can be defined as permanent dilatation of bronchi and bronchioles. It's due to a combination of obstruction and inflammation, usually related to infection, and it can be localized or diffuse depending on the cause and its anatomical distribution. Historically, this was often seen in patients with pulmonary tuberculosis that involved the lymph nodes at the root or the hilum of the lung, where those lymph nodes would squash from the outside the bronchi, leading to obstruction and secondary infection with bronchiectasis. Another classical association is with childhood infections, particularly measles and whooping cough, where there was destruction of airways with secondary bronchiectasis, and often, over time, the production of cardiac failure. Importantly, diffuse bronchiectasis is seen in patients with cystic fibrosis who obviously have a diffuse asthma, a genetic abnormality involving mucus production, and so they develop mucus plugging and secondary bronchiectasis. So here is an example of localized bronchiectasis. You can see normal lung at the top, on the side, on the right, and at the bottom, and on the left bottom part of the lung here, you see obvious dilatation of bronchi with formation of these wide open spaces. There's acute and chronic inflammation in this situation, and also fibrosis, which is essentially scarring secondary to the inflammation, seen here as white patches in and around those dilated airways. Here's another example. Again, normal lung at the top and also at the bottom, and in between you see these dilated sac-like bronchi with very little intervening normal lung tissue left, but associated fibrosis. Clinical features of bronchiectasis are dominated by cough productive of copious sputum. These dilated bronchi contain abundant pus, which is produced as usually yellow sputum. Chronic infection is a significant problem in these patients. This is one of the disorders classically associated with finger clubbing, which you can see on the right here. The normal situation is at the top, where you can see between the two fingers here, and here is the clubbing with loss of the nail fold angle, so that you can no longer see through. One of the important features of bronchiectasis is its association with spread of infection. So you have a chronic seat of infection within the lung, which can gain access to the bloodstream and pass to other organs. So you can get a secondary pneumonia if there's direct extension of infection into the lung. It can be empyema, which is pus in the pleural cavity, if one of these airways erodes into the pleural cavity. Septicemia, which is bacteria in the blood, with proliferation of bacteria in the blood, often associated with setting up of infection in distant sites. Meningitis, where there's inflammation of the lining covering the brain. And then metastatic abscesses. So these are localized areas of infection, abscesses in distant organs. For example, the brain. So brain abscesses secondary to bronchiectasis. So this leads to the conclusion that treating the underlying bronchiectasis is crucial, and certainly in the case of localized bronchiectasis, it may be possible to remove the area of abnormality surgically, which can then resolve the problem. Another complication is amyloidosis. This is the deposition of an abnormal protein in parenchymal organs, particularly the kidney, which can cause kidney failure, and in the heart, which can cause cardiac failure. If the bronchiectasis is widespread enough and associated with significant lung damage, then this may lead to respiratory failure. So that brings me to the end of the third lecture segment, and in these three segments we've looked at factors that contribute to increased risk of respiratory infection. We've looked at the features of bronchitis and bronchiolitis. We've looked at localized and diffuse airways obstruction, defined the terms chronic bronchitis and emphysema, and examined how those come together to form chronic obstructive pulmonary disease. And then finally looked at the pathological features of asthma, particularly atopic asthma and its association with allergy. And then finally the causes, pathological and clinical features of
Well, alright everyone, that is going to be the end of this video. I've completed my 3 lectures. I'm not really sure how long this video is going to be, but it'll probably be around an hour. But I hope that you guys have enjoyed it and got some productive studying done. And I will see you all with another video on Sunday, probably, hopefully. And until then, stay safe, keep studying, and share the video if you liked it. Goodbye.